Okay, this slideshow or recording is going to cover the information for weeks 6 and 7. It's 2 different chapters, chapters 10 and 11. This slideshow is not as long, but it's going to talk about some of the common complications of labor and birth. So the first thing we're going to start with is dystocia. The definition of dystocia is a slow, abnormal progression of labor. And there's lots of different types of dystocias, and we'll talk about some here. But this is the #1 indication for a patient needing a primary C-section. Some of the different types of dystocias include uterine dystocia, arrest of labor, a prolonged second stage or pushing stage, fetal dystocia, pelvic dystocia, and shoulder dystocia. Okay, let's start with the first one with uterine dystocia. This is weak or uncontrolled contractions when she's in labor. They can either be hypertonic or hypotonic. So hypertonic is where the patient has frequent uterine contractions and pain and inadequate relaxation in between the contractions, so like tachysystole, but they're causing no dilation or effacement, or really not that much at all. This is very common in first-time moms. There's a risk for exhaustion to these patients related to a prolonged labor because their cervix isn't dilating like it should be. There's also a risk for fetal intolerance because remember, every time we have a contraction, that oxygenation and blood supply is reduced or cut off to that fetus. So what we want to do is we want to hydrate these moms, kind of get their uterus to relax a little bit so that it can start contracting effectively, and just really try to get the mom to relax a little bit. Now the other one is the hypotonic. This usually occurs once the patient gets into active labor. So they'll contract just fine in that early or that latent phase of labor, but then once they get to the active phase, their contractions are insufficient in strength. So this leads to potential exhaustion and infection because it's now their labor is taking longer. There's a risk for fetal intolerance. For patients who are experienced this, they sometimes will place an intrauterine pressure catheter to measure how strong their contractions are, figure out their Montevideo or MVU units. And these patients a lot of times get augmented with oxytocin, breaking of their water if it's not done yet. And if needed, if fetal intolerance occurs or we just can't get them to contract enough to make cervical change, then a C-section may be warranted. The next type of dystocia is related to arrest of labor. So this is where mom is at least 6 centimeters dilated, her water is broke, and now she just isn't making cervical change. So she either needs to have 4 hours of adequate contractions. Okay, so if she has an IUPC in, we would measure to see what her Montevideo units are, and they're at least 200, or 6 hours of inadequate contractions and no cervical change. So she gets to 6 centimeters, we break her water, we put in an IUPC to measure her contractions, and the MVUs are, 300, and they stay that way for 4 hours, and she's still not contracting. She's having adequate contractions, but her cervix just isn't cooperating. She would be diagnosed with arrest of labor, and then a C-section would be warranted for her. Some of our second stage disorders, so she's in that pushing stage of labor. There's a couple of things that can increase the length of pushing or the time of pushing that somebody pushes for. Her parity. So if this is her first baby, it's normal and common for her to have to push longer than somebody who's had, 2, 3, 4 babies. If you do delayed pushing, so this is when we talked about the phases of stage 2. So we have the latent phase where you're laboring down or waiting until you're ready to push. that you're using the body's contractions to move the baby down so mom doesn't have to push as long. An epidural can increase the amount of pushing that you need to do just because you don't feel as much pain, or maybe you can't figure out how to push as well with that epidural. A BMI can affect the length of pushing. Birth weight of the fetus, so your larger babies, takes a little bit longer to push. If that fetus is in that OP position, so that occiput is on mom's posterior side, that increases the length of pushing. And also the station that the baby's at once the mom starts pushing. So is she at a 0 station, +2, -2, that will all affect how long she has to push for. So a definition of a prolonged second stage of labor, if it's a primate but first-time mom, it's a lack of delivery with 3 hours if she had an epidural. So she's been pushing for 3 hours and we don't have the delivery of a baby. Or if she doesn't have an epidural and she's doing it without pain meds, she's been pushing for 2 hours and we still don't have the delivery of a baby. This would be considered a prolonged second stage or prolonged pushing. A patient who's had babies before, multip, she would get diagnosed with prolonged second stage if she hasn't delivered within 2 hours with an epidural or an hour without an epidural. These patients, when they've been pushing for a prolonged time, are at an increased risk of needing an operative birth. So that means the use of a vacuum or the forceps to help get that baby delivered. They're at an increased risk of peripartum morbidity and some adverse neonatal outcomes. Prolonged second stage puts this infant at risk for asphyxia. So that's really what we're concerned about here with our baby, and we want to make sure that we are monitoring the heart tones and watching our variability and seeing how our baby is doing. One thing I want to talk about here quick, so this isn't one of the dystocias, but this is the opposite of dystocia. This is a precipitous delivery, or a precip, you might hear it referred to. And this is where the patient's labor starts, and within 3 hours, she has a baby and delivers the baby. These patients have an increased level of anxiety and pain. There's an increased risk of postpartum hemorrhage and lacerations. The infants are at a risk for CNS depression. What are risk factors that a patient might experience a precipitous delivery? Well, if she's had a lot of babies, so a grand multip. So if she's had already 5 or more babies, the risk of a precipitous delivery goes up. If she's had a history of a precipitous delivery, and also her drug use. These patients are the ones that, deliver in the car or come in to triage sitting sideways on the wheelchair they're about to deliver. If that's the case, make sure you stay with the patient, okay? Try to be calm, prepare for delivery, get some help in there, because this is the one where the nurse might deliver the baby. Okay, back to our dystocias here. So fetal dystocia. This is where labor is stalled or not going as appropriate due to like the size or the positioning of the fetus. So it can be size, malpresentation, maybe she's pregnant with multiples or some sort of fetal anomaly. So look at the pictures on here. The first one is multiple gestations. Okay, sometimes when you have more than one baby in there, it keeps the presenting baby from being able to drop down in the pelvis, which would normally happen with just one baby in there. Your next picture is of, well, it's almost like a toddler there, but with a very oversized or large head, skull. That would keep the baby from being able to drop down into the pelvis. Male presentation, so we would prefer our baby's head down, so vertex, and with the chin to be tucked. But sometimes you have a face or a brow presentation. Maybe you have a breech baby. Anything like that can prolong the labor. And then you'll see an average size newborn next to a jumbo size newborn. That baby is huge. That too can affect the labor and delivery. So again, neonatal asphyxia is the greatest risk from getting our baby out. Other things that can be with complications with this is we can the fetal injuries, maternal lacerations, and something called cephalopelvic disproportion. That's just where mom's pelvis doesn't match up with the baby's head, the so they get diagnosed with cephalopelvic disproportion. Okay, your next one here is a pelvic dystocia. So this is all related to mom's pelvis and the fetal head fitting. So let's say it's a normal size fetal head. There's no issues with it, but it just doesn't line up with mom's pelvis. So if you go back to the slideshow from the week before, I believe it's slide 6, that lists the 4 different types of pelvis or pelvises or pelvi. You have your gynecoid, your platyploid, those 4 different ones. So if your mom has that platyploid one, there's an increased risk that the fetal head is just not going to fit in there or line up with it correctly, and she is at an increased risk of her labor not progressing appropriately. Okay, so the one type of dystocia that you've probably heard of is what's called shoulder dystocia. This occurs when the birth of the fetus is halted or stopped because the shoulders get hung up and they don't progress through the birth canal. So with a shoulder dystocia, the head will deliver, but then it kind of like sucks back in, and we call that the turtle sign. And you'll see I have a, beware of turtles on here. So that's like the common finding with this, that turtle sign. Because as the head's coming out, it wants to deliver, but oops, darn, those shoulders are stuck, and it pulls it back in. Risk factors that a patient might experience a shoulder dystocia is macrosomia, so is the baby really big? Okay. Diabetes, because those usually grow bigger babies. If the patient has a history of shoulder dystocia, a prolonged second stage, so she's been pushing for a long time. Maybe she's pushing because that baby's really big or it's just not fitting well in the pelvis. An excessive weight gain. What are you going to do if you notice this from happening? There's an acronym. It says be calm. So B, breathe. Do not have the patient push at this point, and you want to lower the head of the bed. E is elevate legs into McRoberts position. I'll show you what this is, but just repositioning those legs sometimes is enough to get those shoulders to get unhung from the pelvis. C, call for help. Okay, why are we calling for help? Well, A, your fetus is stuck, and it's probably going to, once you do get it to deliver, it's going to be stunned and need a little bit of extra help. So that's why you want more nurses and a pediatrician. Anesthesiologists you want, because if you cannot get this baby out within a brief amount of time, you're taking this mom back to the OR to do a C-section and get the baby out that way. And that's when another physician, you're going to want another physician with too to kind of help get this baby out. One thing that the provider might tell you to do is apply suprapubic pressure. So this is where you're going to make a fist and you're going to push down right in the suprapubic area. So not fundal pressure up on top of her uterus, but instead it'll be right above her, like by the pelvic bone. What this does is it should make her shoulders roll or kind of fold together a little bit more, hopefully decreasing that diameter so it can fit under the pelvis. Sometimes what the provider will need to do is cut an episiotomy. This isn't because that's what's keeping the baby from being born. It's not that skin. It's just so that they're able to do some extra maneuvers with their hands and they have more space to work. And then it kind of tells you the different maneuvers that the providers can do. We will watch this video in class next week, but it shows a shoulder dystocia. McRoberts maneuver. So we're going to flex the legs onto the abdomen. Okay, so that's number 1 that's listed there. Really, so when I do McRoberts, we take their legs, we like straighten them first, and then we flex them kind of back almost as far as they can. And then the second thing is that suprapubic. So you'll see where that nurse is pushing kind of right above that pelvic bone there and trying to get that shoulder to curl in over the chest. Now, what do we do if this doesn't work, right? So we're doing the McRoberts and the suprapubic after the provider tells us to. The provider is doing other maneuvers, which are listed down on the bottom right. There's a Woods maneuver, corkscrew, all sorts of different things, just trying to get that shoulder to release. Worst case scenario, if your fetal head is out for too long, is called the Zavanelli maneuver. This is where the provider pushes the fetal head back up into the uterus. They do a stat C-section to deliver the baby that way. This is a last-ditch effort to get this baby delivered. I have never seen this done before, but by the time you get to the Zavanelli maneuver, your baby is severely compromised. So you definitely prepare for resuscitation of this baby. Okay. Okay, so those were our different dystocias that you want to be aware about. Now we're going to talk about just some other procedures that are performed during pregnancy. So this first one is an external cephalic version, or you might just hear it referred to as version. So external, it happens on the outside. We want to get the cephalic, the head, to be down. So this is what's performed on your breech babies. You want to do this before the patient is in labor. So ideally, they're going to do it around 37, 38 weeks. You don't want to do it too early because there's risks that you might need to deliver your baby. And also, once you flip the baby, let's say you would do it at 36 weeks and you get the baby the right position. Well, now if she goes on to 40 weeks to deliver, there's more time for that fetus to, flip to an improper position. So there's a video on here that shows you what a version is. Versions are contraindicated with placental abnormalities. The providers are pushing really hard on mom's uterus. If there's any placental abnormalities, you can cause more issues with that placenta to detach, to abrupt, anything like that. And then again, you're in a bad situation. These are done in the hospital, and the OR crew needs to be on standby. So that means you need to have everyone aware of what's going on. You need to have an open OR. You should have an IV placed in your mom. And then they give her a tocolytic before, terbutaline. This is the third time we've talked about terbutaline, and you know that it relaxes the uterus. Think about why you would want the uterus relaxed in this situation. As a nurse, you're in there charting, and then you're going to keep mom afterwards, and you're going to monitor fetal heart tones and contraction patterns. What can happen with this is if that placenta, like I said, tears away, we're going to be doing a stat C-section. All the force and pressure could cause mom's water to break. And if the fetus is in improper positioning, there's an increased risk that that cord will prolapse and come out first. So that puts her at risk for an emergency C-section too. So there's lots of risks for it. It can be very painful, and it's not always successful either. An operative vaginal birth is either the use of vacuum or forceps to help get that baby out. Now, these should only be used on fetuses where the provider thinks and is pretty certain that these babies will not get stuck. So for example, if you have a shoulder dystocia You don't want to be putting a vacuum on and just pulling on that head because those shoulders are stuck. So reasonings that they might use an operative vaginal delivery, let's say mom's been pushing for a while and she's getting exhausted, okay? Or let's say mom's complete and all of a sudden fetal heart tones go down and we need to get that baby out. The provider thinks, yep, I can help assist this fetus out with mom's pushing efforts, and that would be quicker than taking her back to the OR and doing a C-section. So most providers use the vacuum. There's a couple different types of vacuum. There's a Mighty-Vac, that's that purple thing there. There's also a Kiwi, that's another little one. But you as the nurse, what your job is to do is to document when it's applied and how many pulls and pop-offs that happen. So when the provider applies it, he then or she inflates it or puts pressure, increases the pressure, and then when mom has a contraction and she's pushing, the provider is also applying some pressure to help pull that baby out. This can be used for no more than 15 to 20 minutes and no more than 3 pop-offs. So every time it pops off or comes off of the fetal head is a pop-off. Once you get to that 15 to 20 minutes or 3 pop-offs, then it's considered unsuccessful and that patient should be delivered via a C-section. The other option for an operative vaginal delivery is the forceps. So you'll see a couple different pictures of forceps there. Forceps are found to be less traumatic on the fetus, but more traumatic for mom, so cause more lacerations on mom. Whereas the vacuum is less traumatic on mom, but causes more issues on the fetus. Forceps can be used, again, it's kind of provider specific. It's a little bit more old school practice with the forceps. But that is an option. They might ask for it, and we have someone will bring it to class and show you how they work. Okay, another issue that can happen with pregnancy is post-term pregnancy and birth. So this is where your patient goes past 42 weeks of gestation. These patients have an increased risk of neonatal and post-neonatal death, increased risk of macrosomia, which now increases their risk of needing a C-section because their baby's too big and they might experience fetal dystocia or some sort of dystocia, shoulder dystocia. These infants are at risk for seizures, meconium aspiration syndrome, oligohydramnios, and a postpartum hemorrhage. It's also very common for these post-pregnancy or post-gestation patients to have a category 2 or category 3 strip due to that oligo, and their placenta just isn't sufficient anymore. Your placenta is only made to work up to about 40 weeks, and then it starts calcifying or forming little like blood clots, or the vessels just quit working. So this is a picture of a calcified placenta here. All that white that you see on there, that shouldn't be there. It should all be a dark red hue. And those white spots are calcified areas where blood flow no longer goes through. So MEC stained fluid or meconium stained fluid. So I said this was a risk factor. 10 to 20% of labors have meconium stained fluid. So when a fetus is in utero, it doesn't poop, okay? It shouldn't poop. All that meconium is baby's first poop, accumulates in their intestine, and then they shouldn't release that or poop until after they're born. Well, sometimes if the fetus experiences some sort of stressful situation or a hypoxic event, it can cause them to stool in utero. What we get worried about is that stool floats around in the amniotic fluid. Now, we know amniotic fluid, babies swallow it, it's within their lungs when they're in utero, and normally it's clear. and they cough it out, or it gets pushed out of their lungs when they're going through the vaginal canal. But with meconium fluid, some of that poop can stay within their lungs and cause their lungs to not want to work correctly once they're born. It can collapse their alveoli. So normally when babies are born, they take their first deep breath. It pushes out all that fluid from their lungs, their alveoli fill with air, and they breathe great. Well, now if they have meconium stained fluid in their lungs, their alveoli don't want to open, okay? So then they're going to have respiratory issues. So when mom's water breaks, if you notice meconium stained fluid, you need to notify the neonatal team. You're going to want extra people there just because there's a risk or a chance that baby's going to have respiratory issues and going to need a little bit extra help. Now, it's not for sure that they're going to, but you want to be prepared. There's different studies out there saying what you should do with that amniotic fluid, like when a baby's born, how you should suction it out. Read in your book to see what the best option is, or what they're saying that you should do now for infants with meconium stained fluid. Okay, our next thing is an intraamniotic infection. This used to be called chorioamnionitis, okay? But now they kind of broaden the term to an intraamniotic infection, an infection that's within the amniotic area. Common findings with these patients is fetal tachycardia, okay, so greater than that 160. If you do blood work on mom, her WBCs are going to be elevated greater than 15,000. Her fluid, so the amniotic fluid, is purulent. It's got quite an odor to it. Mom's going to have a fever and she's going to be tachycardic, and the uterus itself is just going to be tender. So if you touch her belly, it's really going to hurt. It's just that buildup of that infection within that uterus. So what are we going to do? We're going to start mom on some antibiotics, antipyretics, so some Tylenol. You're going to try and get mom's temperature down, because if mom has a fever, so does baby. And depending on where mom is in her labor, they might try to continue on with a vaginal delivery, but they're going to be very cautious, okay? So baby's already got tachycardia, but now let's watch, what does its variability do? Are we having recurrent decelerations? And if that starts occurring, then they're going to talk about doing a C-section just to get that baby out and stop exposing it to more infection. Okay, a prolapsed cord. So this we've talked about many, many times, but here's our actual slideshow on it. So a prolapsed cord is when the cord comes out of the vagina when her water breaks. So it can either be hanging all the way out of the vagina, or it can just be the presenting part. So maybe it falls down and it's right above baby's head. So when you go and check mom, you might feel baby's head, but you also feel a cord there. Risk factors that a patient might experience a prolapsed cord include malpresentation. So the baby is not in the correct position, either breech, sideways, maybe it's OP or something like that. Fetal anomalies, a small baby. Okay, if you have a small baby, there's more chance that that cord will fall out instead of the fetus being there and pushing down on the cervix. An unengaged presenting part. So the fetal head is blottable, or it's floating around higher up in the uterus and not over the cervix. Preterm. Well, preterm, you have small babies, right? A lot of the times your malpresentation with preterm, and the presenting part isn't usually engaged yet in preterm. Polyhydramnios, so too much fluid. There's just more pressure as your water breaks. There's more chance that the umbilical cord is going to fall out. Multiple gestation, so 2 or more babies, and then the grand multip. Okay, so what are you going to do if you have a cord prolapse? So think of what you might see on the monitor, what type of decelerations, probably variable decels, a prolonged decel if that cord is really hanging out. Okay. Remember, if you find it, you keep it. Other things that can happen or that can be done with the prolapse cord is you can change mom's position. Okay, so either Trendelenburg used to be the way, but now if you flip her over on hands and knees, but you put like head down, butt up in the air, that should help with gravity to kind of, instead of having that baby put down farther into the vaginal canal, it should bring it back up. You can fill mom's bladder with fluid. Okay, so think your bladder is below your uterus. So if you have a full bladder, it can keep baby's head up off of that cord. Okay, this patient's going to deliver via C-section, so we're going to be wheeling her back to the OR. So hopefully you have an IV in her and everything like that. And you're just going to prepare for a bad baby. All right, the next complication that can happen is a uterine rupture. A uterine rupture, if you look over on this picture, you will see that that's supposed to be her uterus, and you see a fetal foot coming through this tear that should not be there. Uterine ruptures most often occur in women that have histories of uterine incisions. So those uterine incisions, that scar tissue isn't as strong, and therefore it starts to tear or rip apart. When you look at your monitor strip, you can see your contractions are going to be hypertonic or tachysystole. Okay. The patient might complain of a tearing sensation or feeling like ripping. She could have vaginal bleeding, signs and symptoms of shock because she's going to be hemorrhaging. Your heart tones are going to be bradycardic. And if you go and you check your patient, so maybe you checked her before and she was, I don't know, 4 centimeters in 0 station. Well, now when your uterus ruptures, there's nothing holding that fetus in that position anymore, and it's just hanging out within the abdominal cavity. So the station of the presenting part is going to be ascending. So it's, instead of coming down lower out to the outside world, it's going back up inside mom. Uterine ruptures don't always rupture completely. Sometimes it can just be a little bit of like a tear. So if you have your incisional scar, maybe just one side will start to tear and then it gets noticed and they can repair that. But if it completely ruptures into pieces, think of a balloon exploding, then they can't fix that and a hysterectomy is needed. One of the more severe things that can occur in labor, delivery, and in fact the first 24 hours after they have a baby is what's called an amniotic fluid embolism or anaphylactic syndrome. You might hear this as an AFE. It's very rare, but it's life-threatening. Okay, so it can occur during pregnancy, labor, birth, or the first 24 hours after birth. So it's a very high mortality rate. For the patients that do survive, they usually have significant complications or issues, and they're never quite back to their normal self. These are unpreventable and unpredictable. You don't know what's going to happen. So with an amniotic fluid embolism, is what happens is amniotic fluid will enter the maternal bloodstream. So think of times when amniotic fluid could possibly get into a blood vessel. Okay, maybe when they rupture mom's membranes, you guys all felt the amni hook and how sharp that was. When the provider goes to rupture mom's water, there's a chance that maybe they nick a little blood vessel or something like that within the vagina, within the cervix, something like that. Now her water is broke, and then amniotic fluid could find its way into those blood vessels. Another site, would be if there's placental separation, so an abruption or something like that. That placenta is pulling away from the uterus. There's lots of blood supply, blood vessels going to that. Parts of the amniotic fluid could get into that. Uterine trauma or lacerations, okay? C-section, right? We're putting a laceration on the uterus, lots of amniotic fluid there. These patients, what they experience is a sudden, like shortness of breath or difficulty breathing, hypotension. They can go into cardiac arrest. If they're pregnant when this happens, fetal hypoxia, your heart tones are going to crash, and mom can go into what's called DIC, which we'll talk about on the next slide. They could have, or they'll have a change in their level of consciousness, so a lot of times like going unconscious, foaming at the mouth, uncontrolled bleeding. Okay, if you are thinking your patient is experiencing an AFE, you call for help and you prepare for resuscitative efforts. These patients, they're gonna code on you. So you're gonna try and bring them back. They're gonna go to the ICU if they make it, and really it's this kind of supportive treatment to see if they're gonna survive it or not. Okay. Okay, DIC. So I just mentioned this with anaphylactic syndrome. This is disseminated intravascular coagulation. So when this happens is some event happens where mom is bleeding, okay? The body sends all of its clotting factors to that site to stop the bleeding, but then it uses up all of the clotting factors, which leads to hemorrhage and death because there's none left. During DIC, the body breaks down blood clots faster than it can form a clot. DIC is always the result of other issues, okay? So they're not just like, oh, yeah, I have DIC. No, something has to happen that puts your body into DIC. This can be an abruption, an AFE, mom could be septic or preeclamptic, hemolysis, low platelets, hemorrhage, okay, think HELLP syndrome. These patients will need blood transfusions, they're going to go to the ICU, and hopefully be able to get some clotting factors to be restored and come out of it. Okay, so that was most of chapter 10 here. We're going to touch a little bit on chapter 11, which is C-sections. So we have a couple different types of C-sections. We have scheduled and unscheduled. So scheduled C-sections are where, ahead of time before she goes into labor, we are going to plan her C-section. So for example, let's say I go in for my first prenatal appointment and I have a history of 3 other C-sections, okay? They're going to say, you know what, let's schedule your 4th C-section when you're 39 weeks pregnant. So reasons for scheduled C-section is if they've had previous C-sections, if there's a known maternal or fetal health condition. So let's say I have, I don't know, let's say I have a previa, placenta previa, or baby's breech, or there's some sort of heart condition with my baby, or something like that, it'd be better off to just have a scheduled C-section. Male presentation, there's that breech baby. And there's this new thing happening now, which is just an elective maternal request. The mom's like, you know what? I don't want to go through a vaginal delivery. I just want a C-section. This used to be unheard of, but it is becoming more and more popular, and insurances are starting to schedule or to approve it. So if it's not a scheduled C-section, the other type is an unscheduled. So these are ones that occur that we weren't expecting it, okay? Or they come in labor, and then we need to do a C-section. So there's 3 different kinds of unscheduled. We have emergent, urgent, and non-urgent. So let's start with our emergency. This is an emergency, a stat C-section. There is an immediate need to deliver the fetus. For example, if we have a prolapse cord, the uterus ruptures, a category 3 tracing, those are all reasons to do an emergent C-section. The next type is urgent. There's a rapid need to deliver the baby, but it's not like right now, okay? So for example, let's say they present in labor and that baby is transverse. Okay, great. We know we can't deliver vaginally this way. We know we have to do a C-section. But how do we, do we have to go back and do a stat C-section? No, but we need to do it a little bit faster than, dragging our feet. Another urgent would be, let's say we have a known placenta previa. All of a sudden she starts bleeding a little bit, but her heart tones look fine. Okay, great, let's do an urgent. Non-urgent is due to basically labor is going, chugging along, but it stalls out. We know we need to deliver via C-section due to something. For example, failure to progress. Okay, so maybe she's been stuck at 6 centimeters for 4 hours, she's ruptured, we have adequate contractions, but she's just not progressing. So we're going to do a C-section. Or failure to descend. So she's pushing, but she just isn't bringing that baby down. Again, our fetal heart tones look fine, category 1 tracings. So we can, kind of take our time a little bit with this, but we still need to get it done and deliver via C-section. Some risks that are related to having a C-section: postpartum infection. Okay, we just opened mom's abdomen and her uterus. There's a risk for infection. Hemorrhage. You lose a lot of blood through a C-section. Thromboembolic disease, thromboembolism, okay, DVT, maternal death, fetal injury. These babies are born with lower APGAR scores, respiratory issues, and now mom's at risk for a future placenta accreta. Okay, remember that placenta accreta, where that placenta attaches and potentially would dig deeper. Also, she's at an increased risk for a uterine rupture with the next pregnancies. Okay, so when we talk about the care that we provide to a patient with a C-section, these next few slides are going to be about if we have a scheduled C-section. So the patient's coming in, she's not in labor, okay? Her C-section scheduled for, 9 a.m. So she's going to come in around 6 or 7 a.m., okay? So she's going to come in, and what are we going to do? We're going to review her prenatal record, educate her family, make sure that the consent is signed, collect some lab work and review it. Sometimes they have it done a few days before, but if not, you want to collect it, make sure everything looks okay. Make sure her hemoglobin's okay and there's no infection or anything like that. Your patient should be NPO for at least 6 to 8 hours before. If she's not, if she's like, oh yeah, I just went through, McDonald's and had a Egg McMuffin on my way. Well, they're going to make her wait for about 6 to 8 hours after she ate and do it at that time. You want to hook mom up to the monitors and get baseline vital signs and NST. See what your baby looks like. You're going to start an IV. She's going to get a bolus and then some medications. The medications that she will receive, she gets an antibiotic. That antibiotic is given within 30 minutes of when they're going to cut or make the incision. So you don't want to give that too early. Okay, so you want to give that like maybe once right she's walking back to the OR or something like that. Then there's also some nausea and vomiting medications. Reglan, Pepcid, Vicitra is another one she might get. And then a Foley catheter might get placed either in the room where she's getting ready, or if you have a really nice doctor who will let you wait to put that Foley catheter in until she's numb, you can do it back in the OR. Once you get that patient back into the OR, we're now intraoperative care. So what's your role as a nurse? Well, you're going to help her position for the spinal. So she's going to sit the same way as she would for an epidural. You're going to be there for her. Once she gets that spinal, you're going to lay her down and put that little wedge under her to wedge her off to her side a little bit. If she has any pubic hair, especially by the spot where the incision is going to be made, you're going to shave that. You're going to apply a grounding device because the surgeon uses cautery, so we need to have a grounding device on her leg. SCDs to help decrease the risk of blood clots. You're going to count all the instruments and sponges, and you're going to count them multiple times throughout the case. You're going to prep her abdomen, so you're going to wash it with some betadine or iodine, depending on preference. You're going to perform a timeout, and this is to verify the correct patient, correct site, and correct procedure. And then you're also in charge of recording times. So what time did the patient get to the OR? What time was the incision? What time was baby delivered? The placenta? What time, did they start closing the incision? Lots of times you need to keep track of. If the patient needs medications during this time, that's all up to anesthesia. Anesthesia is also in control of monitoring their vital signs and everything like that. Post-operatively, these patients, when they're done with the OR, or even in the OR, I should say too, they're at an increased risk for hemorrhage, anemia, DVT, pulmonary embolism, paralytic ileus, hematuria, infections, and severe headaches. That slide got thrown in a little weird, but we're good. Nurse's role. So what is your role in the immediate post-op care? So when your patient goes to the PACU, monitor her level of consciousness. She's on frequent vitals. So you're looking for hypotension, she's not breathing enough, her temperature. Not only can it go high with signs of infection, but we also worry about it being too low. She's going to be on cardiac monitoring. You're going to monitor her pain, her incision for signs of oozing or bleeding or separation. You're going to have her on eyes and nose. You're going to monitor her sensory and motor function. So as that spinal wears off, it'll start wearing off, and she'll be able to start moving her toes. You're going to be doing frequent assessments of their fundus and her lochia or vaginal bleeding. Monitor her for side effects of anesthesia, and try to get that Foley out as soon as possible. Usually that's more, 6 to 12 hours later. After she's done in the recovery room, you're going to move her out to her normal room. You're going to slowly advance her diet. You're going to get her up out of bed around 6 to 12 hours after that C-section. Get that Foley out, like I said, as soon as you can. Make sure she's peeing okay. Stool softeners and pain meds. And then discharge teaching. This is going to include incisional care. If she has staples, the staples come out on day 3. If she has sutures, they dissolve on their own. Talk to her about signs and symptoms to report. Physical activity or restrictions she might have. Postpartum depression. These are all things that you want to include in your discharge teaching. This information, TOLAC and VBAC, is from Chapter 10, but I thought it tied in better here with Chapter 11, C-section care. So after a patient has a C-section, and she gets pregnant again, there is a chance she could try to have a vaginal delivery after that C-section. So we have 2 different acronyms here. We have TOLAC and VBAC. TOLAC stands for Trial of Labor After a Cesarean. And VBAC is a vaginal birth after a cesarean. So a VBAC would be a successful TOLAC. Okay? So if a patient comes, let's say, she's pregnant again and she has a history of a different C-section, there are some requirements that she needs to meet in order to attempt to try a TOLAC. So the first one is that she can have no more than 2 previous C-section scars. In fact, a lot of places only say 1. She needs to have an adequate pelvis. So if her prior C-section was due to, cephalopelvic disproportion, or the doctor said you have a platyploid pelvis, well, remember, you can't fix your pelvis. You're born with it. So if that's the reason she was a C-section the first time, they're not going to let her or want her to try a vaginal delivery the next time. Low transverse incision. So that's what this picture is. A low transverse incision is like right on the bikini line. That's normal. A classical incision is up and down. If you have a history of a classical incision, they will not allow you to attempt a TOLAC. You also have to have no other conditions that require a C-section. So, for example, your baby can't be like transverse position. You can't have, a creta or a previa or anything like that. And also, you have to make sure you have adequate staff available to perform an emergency C-section. So what we're getting worried about is that uterine rupture here. Remember, if that uterus ruptures, we need to get you back to the OR ASAP. For these patients, if they have a history of that C-section scar, you cannot use cervical ripening medications. So we cannot induce them using that dinoprostin or misoprostol. That is a contraindication in our TOLAC patients. This slide, sorry, was just an extra one thrown in here. But this just talks about more of the discharge teaching for our C-sections that you would talk about with them. The incisional care goes a little bit more in depth. What's normal for vaginal bleeding, what their activity restrictions are, encourage them to breastfeed, and then signs and symptoms of a DVT or PE. Recovery after a C-section takes about 6 weeks before everything is healed up. They'll follow up with the doctor, usually about at 2 weeks, and then again at 6 weeks to make sure everything is going okay. All right, that is everything for exam 2. Like I said, we'll cover this weeks 6 and 7 in class. We'll also spend a little bit more time going over some fetal heart tones with each of those, and then I think we'll have enough time after week 7 to do some sort of a review before the exam. All right, have a good day.